Yes. Looks like this is to No, no, nothing.
Oh my gosh.
That is
So many. One, plus like five. Um, No, so we had. I thought it was quite- I'm sure your parents were. I guess I just. I don't really know how it works. Yeah. Fine, it does that. I got, oh, but I think personally, you know, really. You know, one thing that I have to do. No, I'm not gonna, I'm not going to, if I really have to, I. But no, I'm just talking about the question.
No.
The question. They, oh, yeah. Or you have to do 4 blocks, but you need to get through. Oh, wow. Yeah. Oh. Because and it's 5 people.
They're just over the plan. Over.
But I still.
Immediately.
And you're. It's not like-
Right.
So they could- That's sad.
This is only. The equity castle.
Oh. I don't have to be. Oh, I don't see it. I'm real funny. What?
Oh, This is that. Was great so far.
I'll bring some questions. What is that? Look, I have. So many questions. I have no idea you want me to walk. Yeah, yeah, he's over. Yeah. Yes, it's a house. Yeah, yeah, I was gonna say. Oh, holding, yes. Holding, yeah. I forgot already, this was first thing. Yeah, and then B12. Holding, yeah, but.
Yes.
Yeah.
There's a difference.
United States is. Not the. Yeah. You should eat lunch. Oh, you can have it. It's boring. Here, how do you coach?
Because of my knee, of course.
That's what you need something lines. I know. Oh, yeah. Let's go. You can have. No, no, I'm gonna do something crazy. If faint is not my fault. What did they call? Oh, this. Not. Oh, wait. Oh, yes, my bad. Contaminated factor, yes, yes. I confused it with, I confused it with, I said that. I just said it to the today, but.
All right, let's go ahead and finish this up. Only a little bit more to go. So we just finished Hokum. Don't forget that there's a dilated version. Again, TTN gene. I'm starting to see that question pop up already, which means they're up to date, folks. So that's why you have to be up to date as well. Any questions on the systolic murmurs? All right, here's the last group, the diastolic murmurs. Diastole is when the ventricles are relaxing. So that's a T wave. Begins at the T wave and ends at the PR segment. You got a diastolic murmur, Michael. All you gotta do is ask yourself what valves are supposed to be open. What valves are supposed to be open? Mitral tricuspid, that means they gotta be stenotic. And what valve is supposed to be closed? Aortic and pulmonary. So aortic pulmonary regurg. Everybody understand how to use that word now? Because all you need to see is systolic or diastolic, folks. Your differential pops right out of your head. Because that's all you guys said. Who's supposed to be open? Stenotic. Who's supposed to be closed? Regurgitant. This way you never have to think for 10 minutes about which disease they're talking about. All right. So we got aortic regurg, pulmonary regurg, mitral tricuspid stenosis. So this is just nice pictures for you guys to look at for later. So we call them diastolic blowing murmurs. If they want to graph it, you'll see S1, you'll see S2, and then you see the blowing part right there. So if they want to graph it, that's the way they'll graph it. Comes right after S2 because that's diastolic. Okay. All right. If it increases on inspiration, pulmonary regurg is on the right side. Increase on expiration, aortic regurg is on the left side. Any questions on that whole maneuver? Remember, that's the most common one that they give in every vignette. It's louder when you inhale or exhale. All right, so if you had a murmur, it gets softer when you inhale. What side is it on, Abigail? Listen to what I just said. You had a murmur that gets softer when you inhale. What side is it on? Why is it? How do you know it's on the left side? The opposite of what? No, you got it right, but you just got to say it in the words so your brain knows how you got that answer. Okay, because remember I told you whichever side is louder on tells you what side it's on. So they'll flip it around and say softer when you inhale. Well, let's just say it's louder when you exhale. Okay, yeah, well, they would just flip it around. Yeah, just to make sure you were listening to me and not quoting the last thing I said before. Yeah, watch out now. Again, remember I told you it's a word game. Hopefully you've now been convinced, but it's a word game and has always been a word game. All the test writer does is change the words around, change the story around, and then ask you the same question again. Okay, and that's why you gotta be able to figure out what he asked you, and then say, well, which one of his words match what you're thinking? Because he knows 1,000 ways to say it, but if you understand yours well, you see, oh, that's the only one that says it. All right, anyway, that's diacetyl blowing murmur. Again, nice pictures. Yeah, the editor definitely picked some good ones. I mean, these are all updated, so that's some of these I haven't even seen. All right, anyway, aortic rigors, radius or carotids, just like we said already for aortic sounds, radius or carotid. Louder when you lean forward, make a fist, blow the blood pressure cuff, or squatting. Remember all those maneuvers, Angie. Raise the total peripheral resistance, just so you know what they're doing. And that means the left ventricle has to pump harder against it, and that's why the murmur is louder across the aortic valve. You understand, Anders? You understand, Jess? All right. Now, let's say, Jess, let's talk this out together. Let's say you got aortic rigors. The heart pumps, and the blood goes through the aortic valve out to the periphery, right? But the problem is the aortic valve is supposed to close, and instead regurgitates back in like this. That means the blood will come back into the ventricle. That's what the blowing is from. It's really gravity pushing down, and it sounds like the wind blowing, okay? So that's how I visualize it. So now when you come sloshing back into the left ventricle, what happens to end-systolic volume? It goes up. Now everybody follow. Don't try to write it down. End-systolic volume rises because you're sloshing right back in that left ventricle. And now here comes the next filling. What happens to end-diastolic volume? End-diastolic volume increases because you're filling on top of what's already in there. All right. So EDV goes up. According to Frank Starling, if EDV goes up, what happens to contractility? EDV, Frank Starling curve goes up there. I don't see it go down. Remember, you got to go up first. Okay. So Frank Starling curve says as EDV goes up, cardiac output goes up for quite some time until you hit this peak, right? They'll ask you, how come the person is still alive? It's because of this. Frank Starling forces that's keeping you alive when you got aortic regurg. One more time. When you have aortic regurg, Mabel, you listening? Whenever you have aortic regurg, what keeps you alive in the meantime is EDV keeps rising. That means contractility keeps rising, cardiac output keeps rising. But remember that curve, Frank Starling, you're going to fall off the curve eventually and drop dead. Why? Because you're stretching your myocardial. Active mice are going to separate eventually. Everybody understand that? All right. So if you got all that volume in the left ventricle, is it dilating or hypertrophy? Dilating. Thick or thin walls? Thin walls. Tall, narrow QRS or tall, wide QRS? Narrow means normal size. You just told me it's bigger. Can't be narrow, so it's tall, wide, because you got to go around like this big bag. Yeah. Everybody following that? Tall, wide QRS. What lead will tell you for sure that's the left ventricle? How come AVR starts with R for right and? That cannot be it. We're in the left ventricle. AVL is still not the best lead for left ventricle. I know you're nervous. And when you ever get nervous, you start looking around the room. I see you. Yeah, I would catch you guys with your habits. Okay? Because the more you look around, that means now you're getting nervous because other people are watching. You don't realize you just put yourself on a spot. Like the light is on you now. Now you start forgetting. Anyway, Garrett, what do you think? What lead? Lead 3. Lead 3, V5, V6, the best ones. Yeah, so you see tall, wide QRSs in those 3 leads. That's how you know it's a dilated left ventricle. All right, now, when that blood, watch again. This is an aortic valve. When it flips in like this and the blood comes down like this, the problem is the mitral valve was on its way to opening. And so that regurgitated stream knocks the mitral valve right back into the mitral valve opening. So you get this relative mitral stenosis that goes with aortic regurg, which they call Austin Flint murmur. A for aortic regurg, Austin Flint. If it was the same thing on the right side, it's called Graham-Steele murmur. A relative mitral stenosis. Everybody watch with my hand again. Again, you got to visualize it so you don't have to memorize any of this. Here's the aortic valve. It keeps flipping in like this. The mitral valve was on its way to opening because it's diastole. This valve is not supposed to be here. It's supposed to be up here, closed. Instead, it's down here. So blood is coming down. Same time the mitral valve is trying to come into this area. And the regurgitated stream knocks it right back into the mitral valve opening. And now you have a relative stenosis over here. So now you hear diastolic blowing and a late diastolic rumble, because mitral stenosis is a rumble. See that? So they'll describe both of those. And they'll ask you, what is that? That's called an Austin Flint murmur. Relative mitral stenosis caused by aortic regurg. Question, Steve?
So there's nothing wrong with the mitral valve.
Nothing wrong with the mitral valve at all. It's just
It's like
it just acts like a stenosis because the regurgitant stream just knocks it in there a little bit. So it sounds like there's a little stenosis there.
and then we'll give the clinic of the mitral.
It'll give you the same clinical presentation as mitral stenosis. So Austin Flint murmur, now you know what it is. Now, let's keep talking down some more, Jess. Ready? Don't look around, just look at me, just focus on me. Focus on me, all right. So now, as blood goes in, EDV goes up, cardiac output goes up. You hear me so far? That means when the ventricle contracts, more or less blood goes out. More. That means the systolic pressure in the aorta goes up or down. Goes up. Everybody understand? More blood would distend the aorta, but if you distend the aorta will contract even harder and squeeze most of that blood right back in the left ventricle. So what happens to volume in the aorta? The volume in the aorta is after the aorta contracts and push it right back in the left ventricle. So the volume is low up there. So that means systolic pressure is rising while diastolic pressure is dropping. This is the wide pulse pressure they're always talking about with aortic regurg. And they'll actually explain that. Or the questions I see now, they say, which one of these blood pressures goes with aortic regurg? You just look for the widest pulse pressure on the list. That's it. Pulse pressure is systolic minus diastolic. So 120 minus 80, which is the normal numbers, right? 40 is the pulse pressure. But you see one that's like 90, 100, 110. You say, oh, that's aortic regurg for sure. All right, another way to say that, besides widened pulse pressure, bounding pulses. That's because systolic is so high, it feels like it's slapping your fingertip. That's why it feels like it's bounding, like it's jumping up real fast. All right, head bobbing is kind of interesting one because the head goes up there and then drops back down and down like that. Because a lot of blood comes up and then the blood goes back down. So you can actually see that. That's system. Obviously, it's got to be somebody who's tiny because, you know, big people, you ain't going to see that neck move. If it's a thin person, then I can see it. All right, so head bobbing or Quincke's pulses. You can actually see their pulse underneath the nail bed. Now, if you look at your nail bed, you can't see your pulse. But if your pulse pressure is wide enough, I can actually see the blood swishing back and forth underneath your nails. And Dr. Quincke described that, so they call it Quincke's pulses. So all these mean the same thing. That's why I'm giving them all to you that way in case they mention any one of them. That's all you need to make the diagnosis. What about in pulmonary regurg? Radiates to your back. Remember, your lung is in your back. So here's another way, rather than louder when you inhale, another maneuver. They say, oh, you can hear it loudly in the back. Your aorta can't be going to your back, but your lungs are in the back. Louder when you inhale, that you should already understand. And then a Graham-Steele murmur is when you have relative tricuspid stenosis, like we already discussed. Diastolic rumbles. Diastolic rumbles, man. Now the sound made, let me draw it for you if you want to. S1, S2. The rumble goes out in a nice straight one like this. I guess I should have made the other one a little more crescendo. Hang on a second. So this one, yeah, this looks more like a rumble. So blowing is loud and then like that. So half a diamond is decrescendo because it's coming down. All right, whereas this one is a rumble. It's just all right, so diastolic rumble. Why is it a rumble? Melissa wants to know. It's your turn, Melissa. Ready or not? Here it comes. All right, so you got diastolic rumble. Let's say you got mitral stenosis, let's say, okay? So you got a stenotic valve like this, right? Left atrium is in front of it, right above it. So left atrium wants to push hard to get that blood in there. Follow? If you got resistance, you're gonna hypertrophy or dilate. Huh? Remember resistance, hypertrophy. All right, everybody got this down by yeah? All right, remember, resistance, hypertrophy, volume is dilate. Make it automatic. So you don't have to think for a second and then change your answer to the wrong one. All right, just make it automatic. All right, so you got resistance. hypertrophy. But just think about a weightlifter. That's resistance training, lifting weights. Follow me? All right, this way you have a way to remember. So now, that means the atrium will then get big right here in front of it. You follow me? That means now you have the physiology of a funnel. You guys ever seen a funnel cake at a fair? You know, funnel, big at the top, narrow right there in the middle, down at the bottom. It's got a skinny middle, right? If you pour water into a funnel, it starts swirling around, trying to get to that hole and get out. Bear with me? What you're hearing, Melissa, is the blood swirling around your atrium. You hear whir, 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 trying to get to the middle and get out there. Everybody understand? All right, so that means if I got a diastolic rumble, what are my two choices? Melissa? Huh? No, try it. Just try it. Okay. Ashley, diastolic rumble, what are my two choices? Mitral tricuspid stenosis, you're gonna hear an opening snap or ejection click? Opening snap. That opening snap gets louder when you inhale. Which side are we on? We're on the right side, which means the diastolic rumble is from what? Tricuspid stenosis. What's gonna have my CVP rise or fall? It's gonna rise. Everything's backing up. You understand? CVP, central venous pressure. You understand? So what happens to right ventricular filling? Decreases, so pulmonary blood flow. Decreases, so pulmonary capillary wedge pressure. Decreases, S2 splitting, wide and narrow. Remember, the widening is based on how much volume is coming across. If you tell me there's less volume, that means it's gonna be narrow. Follow? Oh, makes sense. You only missed one. Only missed one now. Good job. See, I told you, just gotta stick with it. Okay? All right. Any other questions from anybody here? So diastolic rumble. Now we get to pathology. Here it comes. Any questions at all? Here we go. You got cardiomyopathies. All right, here's another exercise, folks. I'm gonna tell you your patient's heart is elevated. You tell me anything else you know about your patient. Zena, you're first. High volume. Bryce, tell me something about your patient.
We're starting with dilated, right?
Yeah, just tell me anything else you know about your patient.
So he will have a S3.
S3. Paul, tell me something about the patient. It's a volume problem. Pablo, tell me something about the patient.
For volume,
No, you guys, all three of you can't say volume now. Everybody's got to give me something different. Okay, I've heard volume 3 times already. All right, so you got to tell me something else. Something that you know because it was a dilated heart.
you already said S3, dilated heart, volume. It's compliant.
What do you mean? Increased compliance or decreased compliance?
It's increased.
Okay, increased compliance because it's stretching too much. Montessori, tell me something about the patient. Thin wall. Neha, tell me something. Wide, tall, QRS. If you want to know if that's the right age, right ventricle, which lead would you verify it? That's left ventricle. I want to see right ventricle. Yeah, lead 2. Only lead 2 sees right ventricle. All right, very good. Tell me something. Calvin should be prohibited. Check your out. Where's that girl, boy? I like that one. All right, Bailey. Pulmonary stenosis, that's dilated. You can't give me a resistance answer. I mean, that's why we're practicing this, so you don't mix the things up, folks. Pay attention now. All right? Truckers regurg, any regurg, I don't care. That's what I'm saying. That's what this exercise is about. Just give me any term you can think of that goes with that word right there. All right? Item. Systolic dysfunction. Decreased contractility. Come on, Reed. Esther, woo, pull that female card, girl. Yeah, I like that one. All right, what we got? What we got? Sandra. Huh? And diastatic volume is what? Increase. Very good. Andres. Decrease. You said decrease CVP? Oh, increase CVP. Okay, very good. Lauren. Decompensated. Come on, Anna. So. So reduced ejection fraction. Remember, you got lack of contractility. I know him.
1 second.
I know. He stole it right from underneath you. Okay, beta blockers can be used to treat it. Yeah, it works in dilated hearts. All right, Cynthia. Increase preload. Come on, and increase pulmonary capillary wedge pressure. Come on, Miguel. What? Aortic regurg, Rachel. Oh, somebody already said that's 3. Can't say the same thing. What would be the most common presenting symptom for them, Rachel? Shortness of breath, what else? Honestly? Increase intracellular volume, Kathleen? What? Peripheral edema. What would be the most common presenting symptom for these patients? Maria? Symptoms? Weakness, shortness of breath. What's the most common presenting sign? Trachea dyspnea? Oh my God, what infections do they get? Pulmonary UTI. What's the most common bacteria for pulmonary infection for them? Staph pneumonia followed by? H. influenza followed by? And say catarrhalis. What's the most common virus? Adenovirus. They want a UTI now. Top 3 bacteria? E. coli followed by? Proteus followed by? Klebsiella, they say nitrate negative. Enterococcus, they say postcoital. Staphylococcus, they say virus. Adenovirus. What's the skin look like?
Dry.
Dry? How about the hair? Brittle? Bone marrow? Bone marrow.
Dry.
Just say suppress, suppress,
Suppressed.
suppress. What part of the nephron shut down first? PC2. What kind of cancer could they have picked up if they lived long enough? Skin followed by, GI followed by, bone marrow. But wait a minute, if I ask you, what are you worried about in these patients? What organ do you worry about first? Brain followed by, heart followed by, kidney, but if they start sacrificing organs, who gets sacrificed first? Kidney followed by, heart followed by, brain. What's the most common cause of death for these people? Heart failure. How come they get, wait a minute, she's rolling now. How come they get calcifications underneath their skin?
Ischemia.
Why is ischemia?
Oh, dehydration.
Thank you. Get that girl some room out there in the joint, boy. Look at that. Now, see, that's what I'm talking about. That way, you can give me a word, you can tell me the whole profile if I ask, and you can explain something if I ask you to explain it. See, because you got all the patterns now. You don't have to, ooh, let me go look that up. It's a low volume state. It's not pumping enough. That's all I need to know. Low sodium, low chloride, low potassium, low calcium, metabolic alkalosis. Look it up, see if I made a mistake. I'm telling you, folks, the benefit of knowing the patterns is you're way ahead of the test writer. He always thinks you're gonna have to drown in all these details. And I'm saying, no, you don't. If you know what normal was, you wouldn't have to worry about it. You just assume it's another one of them. Don't doubt yourself. Just say, yep, it is. But this way you can answer your question and still be over 90% accurate and you didn't even look it up. Victoria, you have a question?
Yeah, sorry, what did she say was the reason for the calcifications?
Calcifications, low volume state. Remember? Alkalosis favors precipitation with calcium.
Oh, right, okay,
Yeah,
thanks.
so they get stones, they get calcification stones and the skin all the time. Michael,
Is GFR in this case higher or low?
GFR, let me ask Maria, she's my consultant here. Maria, is GFR high or low? In the dilated heart? You got a dilated heart. That means decreased contractility, everything you just heard. You're not pumping it to the kidney, it's just decreased cardiac output. That's the problem in dilated hearts. Yeah, so decreased GFR. Yeah. All right, everybody understand? Okay, online, your turn now. Your patient has a hypertrophic heart. Tell me something about the patient. Pablo,
What heart?
a hypertrophic heart, Pablo. Tell me something about your patient.
Perfect heart. It has an S4.
Has an S4, Mabel.
It is diastolic.
Diastolic dysfunction. You got to say it that way now.
Oh, diastolic
Diastolic
dysfunction.
dysfunction. All right, very good.
It's also
Leslie.
tick wall. Okay.
Oh, no, that was, now she wants to roll with me. Huh? Okay. All right, very good. Leslie. Leslie, your turn.
Diastolic dysfunction,
Somebody just said that one. You can't use that one.
S4,
S4 just said that one too. Same person.
stenosis,
There you go, stenosis. Syed. Syed, Zakaria, not back. Jolita, tell me something about the patient.
Thick wall.
Big walls, Ryan Ford. Something about the patient.
Let me see, I already said stenosis, increased pressure.
Increased pressure. All right, Mamita.
So increase in CVP due to blood not being able to enter.
Increased CVP. Sounds good. Eric.
Decreased compliance.
Decreased compliance. Hendrick.
Tall, narrow QRS.
Tall, narrow QRS. Brenda Rivera.
contracts harder,
Contracts harder. Akuna Mizzou.
Compensation.
Compensation. Elizabeth.
decreased stroke volume,
Decreased stroke volume. Adonis.
Could I say like it's S4 seen in athletes?
As for senior athletes. Muhammad Khan.
Regurg.
No. Hypertrophic. Regurg is a volume problem. I told you guys don't mix it up.
Oh, yeah.
Hypertrophic is a resistance problem. So give me something else.
High blood pressure.
Okay, high blood pressure. What do you think is the most common presenting symptom for these patients, Avi? Thank you very much. Yeah, don't start mixing them up now. All right, what infections did they get? Pulmonary UTIs, what's the skin look like? Dry hair, brittle nails, the falling apart, GI symptoms? So nausea, vomiting, diarrhea. What part of the nephron was shut down first? PCT. What kind of cancer can they get if they live long enough? Skin followed by? GI followed by? Bone marrow. What's the most common cause of death? Okay. Give me one drug that'll help them live longer. Hypertrophy. Beta blockers. Give me one that'll help them live longer if they're dilated. If they're dilated, give me one drug that'll help them live longer. If they're dilated. Oh, the Johnson treats symptoms, but doesn't decrease mortality. ACE inhibitors fine. All right, folks, this is what I'm saying. Put all that information you're learning to work. It saves you a ton of reading. It saves you a ton of reading. Okay? It's just that we're learning it in chunks and applying the patterns. Now, see, I can just give you 4 categories for all cardiomyopathies and we're all covered. Signs and symptoms the same for all of them. That's not gonna help you. That's why it's just a few key words. The reason why I do this exercise, folks, is because the vignettes for heart disease are very long ones. If I ever get lost, I look for one of these 4 words. I'm out in 2 seconds. I just say, ah, hell, I'm just gonna go with this. Why? Because they said hypertrophic. Good enough for me. That way you find your way back and you still get the right answer. Okay, but in case you get lost about which hypertrophic disease it is, as long as it's hypertrophic, that's all I need. I can answer the question, look it up later on, which one they were talking about, because I don't know. But the physiology of hypertrophic is the same for all of them. Okay, so do not get lost and then panic and then just start guessing again. Find one of these words, you find your way to the answer. All right, restrictive cardiomyopathy, Ashley. Restrictive cardiomyopathy means that there's something in the way. So restricting actin and myosin from interacting. You understand me? Okay. Most common is fibrosis. So cardiovascular disease or collagen vascular disease, right? What's the most common vasculitis in children? HSV in adults. Hypertension and diabetes. Give me a drug. A drug that causes fibrosis. Nola, what happened?
You didn't like it, you saw my face.
That's right. Should have looked at me. Cynthia. Give me a drug to be the answer. I'm not on pulmonary, I'm on cardiac. That's how you know Canada can't be the answer. Ida. Atrial doxorubicin is the one you learned that causes cardiac fibrosis. All right. But it could be amyloidosis. That means protein is in the way. It could be hemochromatosis. Iron is in the way. That's what I mean. I can visualize. It just means something is in the way between these 2 guys. And that's why you don't get the same contraction anymore. That's restricting their sliding action. That's what restrictive means. Okay? All right. Primary hemochromatosis has which markers? Anybody remember the marker for that one, Zena? Primary hemochromatosis has what marker? And Paul. A marker. All right. Anybody remember the marker? Gloria? HLA-A3 on chromosome 6. People with hemochromatosis have a higher incidence of Listeria and Vibrio infections because those 2 bacteria love iron. So in case they ask you for what bacteria die from, that's how to remember that. Vibrio and Listeria love iron. So hemochromatosis, if they're septic, you pick one of those 2. Constrictive, finally, Kathleen. Constrictive means something's outside of the heart, squeezing it down like that. You understand, Kathleen? Something outside, that's called tamponade. That's usually blood. Gunshot wound, stab wound. Okay, that's why we took them all to surgery. Okay? Did you have a question, Mabel?
Yes, sir.
And what's your question?
Please, what bacteria do you say that cause iron? That cause, is it?
I don't know,
That's-
something wrong
that-
with
They like iron or something
mic?
like that.
I just said it. Something must be wrong with that mic, Mabel.
It says Vibrio allosterine or something.
Vibrio and Listeria. Listeria.
Okay. Vibrio listeria.
Vibrio and Listeria.
Okay,
Two
Vibrio
different
cholerae,
bacteria.
right?
What?
Is it Vibrio cholerae?
Cholera. Vibrio cholera.
Now you're speaking my language. Okay.
Yeah. Miss Mabel. All right. So tamponade is the most common cause of constrictive. It's usually blood from a stab wound or gunshot wound. Okay. What clues do you get? Kussmaul sign. We discussed this several times already. Increased JVD on inspiration. It means there's positive pressure in your thoracic cavity. Blood can't go in. Pulsus paradoxicus, an exaggerated drop in pulse or blood pressure. That's because if it can't come in on the right, can't get to the left either. Okay. Trauma is the most common cause in both cases. What do we do for tamponade? It's called pericardiocentesis. Pericardiocentesis is something they want every doctor to know, so here it goes. You find a xiphoid process. You can find it easily on anybody. Male, female, doesn't matter. Find a xiphoid process. stick a large needle, large gauge needle, remember, your blood, stick, so it's got a big open needle, usually 20 gauge, okay? Stick it right underneath the xiphoid process and then aim straight for the left shoulder like that. If that needle goes that way, it goes right into the pericardial sac. How do you know you're in the right place? Because as soon as the blood comes in, the syringe will start pulling back. That's blood draining. How do you know that's actually blood in the pericardium? Blood that's in the pericardium clots. Blood that's in the ventricle does not clot. So that's why as soon as blood comes out, as soon as you, that means at least the pressure's off. You take that syringe off, squish some of that blood on a piece of gauze. If it clots, that's in the pericardium. If it does not, you're too far in, you're in the ventricle. Everybody understand that? That's how you save a life now. That's why they want everybody to know it. That's what I'm teaching you here. It's a real easy procedure to do. As long as you remember, landmark. You got an easy landmark to find anybody. Even when they're obese, you can find it. Okay? And just aim for the left shoulder. It goes right into the pericardial sac. Since you see blood and you take syringe, squirt on the gauze. If I see a clot, good. I'm in the right place. Put the needle, put the syringe back in. Yes. No. So the question is, was there any difference in resistance in the pericardial sac versus the ventricular wall? There isn't. Because when your needle goes in, remember it's got a sharp point, it goes right through both of them. Yeah. No. Right, exactly. Where you can feel a pop. Yeah, you won't feel this one. It just goes right in. That's why they say check. All right. Because they don't want you to stick the needle all the way to the ventricle and the blood's coming out. It's like, damn, look at all that blood you had in there. 8 liters. I think you're in the wrong spot. Okay. Yeah, so they don't want that to happen to you. Anyway, that's kind of myopathies. Now, effusions. Notice some of this is review. You've already seen effusions. Transudate means you're mostly water. You understand, Kathleen? Transudate means mostly water. Exudate means mostly protein. And here's the 2 best clues. All right, but they can use other things. So specific gravity and proteins, so normal protein is 4, albumin is 4 grams. So that's why they use 2. If you're less than half, that's a transudate. More than half, you're exudate. But what I've seen is they play around with other proteins. I've seen them use AST, LDH, GG2. Who the heck cares? It's a protein. That means whatever protein they give me in that collection of fluid, I compare it to the same protein in your blood. If the 2 are under 50%, one over the other, less than 50, that's a transudate. 50% or greater, that's an exudate. Now you have to remember the discussion we had about this. Because I gave this to you before. If you have a transudate, that's mostly water. Anybody remember the most common cause of a transudate? When it's mostly water. Anybody remember the most common cause? Folks, that means you got too much water in the plasma. Why would you have too much water in the plasma? As it's heart failure. So you're correct. What's after heart? Remember, that's like 90% of the time. After that, renal failure. See that? Because you got too much water and you're not getting rid of it. So you're not pumping it forward, heart failure. You're not peeing it away, renal failure. Or you're hypothyroid, which means none of these glands are working. See? If you go in order, folks, you'll get almost every question right. Just go in order. Or maybe you don't have enough protein to hold on to the water. Dave, what would you have enough protein to hold on to water? Maybe you're not eating enough. What do you call that? You're not eating enough protein. There's a word for that. Kwashiorkor. Everybody listen to how I'm making my transition. If you want to remember the list, you got to just talk out the physiology and the list pops back in again. You have too much water. Why do you have too much water just hanging out? Maybe you're not pumping it forward, heart failure. Maybe you're not peeing it away, renal failure. Or maybe neither one of those organs work, hypothyroid. Or physiology says, maybe the proteins are the problem. You don't have enough protein. Well, why is that? You're not eating it. Maybe you're not making enough. Jess. What's the disease process called? You're not making enough protein. You're not making enough protein. No, Josh. It's called liver failure or cirrhosis, Jess. Remember, most of your proteins come from the liver. So you have called the cirrhosis, Josh. Yeah, remember NAFLD now. Okay, very good. Remember you're peeing it all the way, Jess. It's called nephrotic syndrome. And what's the most common nephrotic syndrome in children, Jess? No, that's nephritic, more nephrotic. Most common nephrotic syndrome in children. Ashley wants to help you. Minimal change. What about in adults, Ashley? Most common nephrotic syndrome in adults. First thought? All right, Karis? Not hypertension, diabetes. All right, Ida? Focal segmental is the most common cause, but it's caused by hypertension and diabetes.
Not fair.
No, not fair. Yeah, right, not fair. On the test, it won't give you, you gotta pick focal segmental. Then if they ask you the cause of that, then you can say hypertension and diabetes. But you gotta make sure you pick the right term. Words matter when you get to the test. She says, okay. And then maybe you're allergic to protein. That's called celiac sprue. What is the rash that goes with celiac sprue? Sonia. Oh, Sandra, sorry. What's the rash that goes with celiac sprue? Zena. Dermatitis herpetiformis. Looks like a herpes rash, but it breaks out on the thigh at the same time they get diarrhea. So that's how I know it's not herpes. Okay, celiac sprue. What's the screening test for a newborn baby for celiac sprue? Andy DeVilma.
Is it? I'm not sure right now, sir.
No problem, Elizabeth.
Sorry, can you repeat the question?
So what is the screening test for celiac sprue in a newborn?
Does it have something to do with is that the transglutaminase?
Yes, it is. Say it with more confidence next time.
Okay.
You gotta trust what you're thinking, girl. Come on. You got it right. That's good. Oh, is that your dog? Does he know the answer to the next question? All right, anyway, but that's, remember, we're gonna be drilling as we go, folks. Be ready.
Excuse me, sir. Please, what do you call
Yeah.
the rash in celiac sprue, please?
The rash is called dermatitis herpetiformis, Mabel.
Please, can you spell it? Dermatitis. Can you spell it piriformis, please?
Dermatitis?
No, the piriformis or whatever. The last one
No,
you
not
said.
piriformis. Herpetiformis. Looks like herpes. You see it?
Yeah,
Mabel.
thank you. Thank you, sir.
Okay, there you go. Yeah, okay. All right, filtration force equation. You've seen this before. Remember, 2 forces for minus 2 forces against. So hydrostatic pressure in the vessel plus oncotic pressure outside the vessel minus oncotic pressure in the vessel plus hydrostatic in the interstitium. If the filtration force is a positive number, Armando, what does that tell you? What? Yeah, water will leave the vessel. Remember, filtration, that means will water leave? That's what filtration means. So if the filtration force is positive, water will leave. If it's negative, water will come in. Remember I told you, I've seen questions where you got to interpret the result. Okay, but it's just 2 forces for minus 2 forces against. Any questions on this equation? Again, you've seen it before. I'm just reviewing it for you. How about congenital heart diseases? These are the 4 most common congenital heart diseases in your body. Well, not in your body, sorry, in children. So Ashley, this is yours. These are 4 most common congenital heart diseases, all right? I'm gonna give you clues, and you tell me which one I'm talking about, all right? Here we go. Holosystolic murmur. No, VSD. Remember, when you hear the term holosystolic, that means there's a pressure gradient. Talk it out first. Pressure gradient that can only exist between a ventricle and an atrium. And that's tricuspid regurg, but mitral regurg, and then left ventricle and right ventricle, that's VSD. That's what I'm saying. Use the word and talk it out again. Okay? All right, Jess, you're next. I'm gonna give you some clues. You tell me what I'm talking about. All right, fixed-wise splitting of S2. ASD is correct. Continuous murmur. That's not on the list. Now remember, there's the 4 answers right there. Isn't that coarctation? Continuous murmur, cares. PDA. The word continuous, again, physio, folks, means there's a connection between the artery and vein. That's the definition I gave you guys. So you don't have to memorize this stuff. You just got to know the meanings of words. And then it'll conjure up the picture in your mind again. Okay? So continuous or machinery means you have a connection between the artery and vein. That's your PDA. Rib notching, Steve. That's your coarctation. Turner syndrome. Abigail. Coarctation again.
No.
What?
What did you say about coarctation?
About who?
You said something about coarctation.
Coarctation. The 4 things are right here in front of you, Mabel.
I know you said something about coarctation. You were trying to explain it.
Coarctation. Yeah, coarctation is rib notching.
Yeah, what did he do?
What?
What did he do?
No, Mabel, listen up. All right, make sure you focus. We're doing a drill where I give you a talking about the in front of you.
Okay.
Yeah, that's what I'm saying. All you gotta do is figure out what disease I'm talking about. Just throwing out clues for you.
All right.
All right. So we're ready to process, Maria. There's the 4 answers right there. Differential pulses. Coarctation is correct. High incidence of hypertension. So, what? Okay, she passes. Chris. Why coarctation? There you go. That's what you understand, Sabu. So like I said, just talk out the physio. That way you can see it. Or you say low flow to the kidney. Yeah, that's going to set off hypertension. The high incidence of hypertension, coarctation, because you got a resistance in the way. Resistance means pressure's got to go up. And then you have low flow to your kidney. There it is. RAS system is stimulated. And hypertension doesn't always go away after we do surgery. So in case you see that question, it does not go away right after surgery. It goes down over time, but in some people, it never goes away. It means the whole renal system has already been ruined. Nothing you do except keep on medicated for the rest of their lives. Okay? All right, now, these are the 4 diseases in order. Do you understand, Zena? I'm going to ask you one question. Now, I have to just answer this one question. Okay? My question for you, Ms. Zena, is which one of these congenital heart diseases would you see in a newborn child who's 2.5 days old, who was born with Lululemon syndrome, and has got one almond-shaped eye on the left and a diamond-shaped eye on the right, walks with a limp on Sundays when the sun is out and shining bright, especially in the wintertime? Why the VSD? My child is grown up. My child is grown up now. Come on, that's what I'm talking about. You're not just making up all kinds of crap. All right? That's what they do, folks. Give you some strange syndrome you never heard of. Guess what? They know that students will start obsessing about the damn syndrome. It's an answer to the question. They say, what's the most common? You don't need to know what the hell syndrome is. Just pick it and keep moving. That's why I give it to you in order. I'm telling you, I've seen that question several times, folks. I didn't read past most common. I just clicked. That's what they hope you do. Drown in the syndrome you never heard of and start obsessing because you don't know what it is. And then you can't even answer the question. You don't need to know what syndrome is to answer the question. They said most common. That I know. That's what I keep giving you guys. Most common, most common, most common. Anytime you don't know, go back to most common. Call it a day. Okay? All right, Karis. Rib notching is when you got narrowing in the aorta cord tissue, right? So the blood would then divert through the subclavian artery, down your arm, and then come back around through the intercostal arteries, ribs, to get back to the aorta after the narrowing. And you can actually see those vessels will enlarge and they erode the inferior surface of your ribs, and we can see that on X-ray. And that's what rib notching is. All right, what about cyanotic heart diseases? The most common cyanotic heart disease, you've heard it before. Transposition of great arteries, because remember, we all start out with transposition. So if you pull out a baby early, he's stuck with it. That's number one at birth, followed by tetralogy Fallot. Number two at birth, but becomes number one after a month of age. For every cyanotic heart disease, Josh, every cyanotic heart disease is a right to left shunt. That means you need a left to right shunt to correct it. Which one is every baby born with? A left to right shunt called what? No, what's the one that every baby's born? PDA. That's why these diseases are also called ductal dependent. That means you depend on that duct staying open. By 48 hours, 95% of PDAs are closed. That's why they turn blue. They turn blue in the first 48 hours, because once that PDA closes, that's it, they turn blue. Because now you just got a right to left shunt with nothing to correct it. That means the first thing you gotta do is reopen that PDA. Josh, hit me one good time. I'll process it, reopen it. Then we're gonna take the surgery and create our own shunt called what, Chris? We're gonna go take the surgery and create our own shunt by the name of? By the name of Elizabeth Chalakis. You know that shunt's name?
Is it like Beckett's or something? It's on the tip of my tongue.
It's what? And close enough. Blaylock. Blaylock Taussig shunt. Blaylock Taussig shunt. All right, now to Tetralogy Fallot, Akuna Mezu. You there?
Yes, I'm here.
Great. Tetralogy Fallot says tetralogy. That means there's four things involved. What are the four things?
Pulmonary stenosis,
Pulmonary stenosis is one.
VSD,
PSD.
overarching aorta,
Overriding aorta.
and hypertrophy of the right ventricle.
And the RVH. Very good. Let me offer it to you this way. It's really a cause and effect. Remember, transposition of great arteries, the spinal memory never came down at all. That's why no spinning happened. Tetralogy Fallot, the spinal memory came down when you spun too far to the right. So you start out with overriding aorta, one, which then encroaches on the pulmonary valve. Pulmonary stenosis, two. Pulmonary stenosis, resistance, RVH, as a result, three. And then right ventricular hypertrophy, you start shunting through the VSD, so it stays open. Four. The four things are related. They're not four independent things. There's four things that are connected to each other. And that way it makes it easier for me to remember them. Because one day I could visualize the whole thing. I said, oh my God, yeah, I've been memorizing this for years. Okay? Once you visualize it, now you see the connection. All right, which one of those four things determines the ultimate prognosis for this person? Nate. Tetralogy Fallot, one of them determines the prognosis. Which one? Not the hypertrophy, Matt. Matt's Gloria. The pulmonary stenosis, the one that determines how much blood gets oxygenated, is the way I explained it to you guys. Always think with physiology, okay? Pulmonary stenosis, the more severe it is, the worse the prognosis. That means hardly any blood is getting oxygenated, okay? So if you're born with mild pulmonary stenosis in Tetralogy Fallot, the doctor may not even detect it. I told you the VSD does not shut for like 3 or 4 days. And so these children go home until somebody calls you with a TET spell. Anybody describe one of them for me? Anybody describe any one of them? Yeah, this is when they're older, they fall back on their back, put their knees to their chest, or they'll squat and grab their knees, same thing. That's squeezing all the muscles and therefore compress all the arteries. You raise your total peripheral resistance. And then blood goes back up the aorta, spills through the PDA, back into the lungs to get oxygen a second time. And so they feel this burst of oxygen when they stand up. What's the other one, Amy? TET spell, number 2. Rees all over it. Yeah, they cry or throw a tantrum, and what happens? They turn blue. That's because when you're crying, you raise your pulmonary resistance. And then RVH, you start shunting right to left through the VSD. Okay? I remember I told you now they're asking the reason for it, not just make the diagnosis. What is the explanation now? That's what I say. You got to know your physio and forward and backward. That way, no matter how they ask it, you already know the answer. Yes, sir. No, pulmonary stenosis is not going to cause pulmonary hypertension because you have very little blood flow going to the pulmonary. All right, it's the PDA that will cause pulmonary hypertension because it keeps spilling blood in there.
So it's true that since pulmonary hypertension is a irreversible cause, but
Yeah, pulmonary hypertension is irreversible. That's why the amount of blood flow through the pulmonary is the deciding factor for prognosis. All right, Mabel, you have a question?
Yes, sir. He said that when the baby cried that they turn blue and erase the total peripheral resistance and what again?
No, wait a minute, Mabel, you're getting it all mixed up. When they cry, they're raising their pulmonary resistance. And that's why they shunt right to left through that VSD. Did you understand that?
No, he said when they cry that they raise their the resistance, right? Pulmonary
The
resistance.
pulmonary resistance, that's correct. That's
And
why
they
they start
shunt.
shunting right to left through the VSD. Make sure you say the whole thing. That's why they turn blue. Because you got blue blood going to the left. As soon as they stop crying, blood goes back to the other side. That's why they pink again. Okay? All right, Mabel, this one's yours. Ready?
Yes, sir.
Mabel. All right, Mabel, your patient is tricuspid atresia. This is going to affect S1 and S2.
So what are atresia, sir?
Are you looking at the same list I'm looking at, Mabel? You keep asking me
Yeah.
questions. Is this showing up on your notes?
Yes, sir. He said aortic atresia.
Tricuspid. We're going in a row here. Mabel, watch the row. I started with transposition tetralogy. Now I'm on the third one. You're gonna wear me out by the time we get done this week. Atresia, Mabel, you with me now?
Yes, sir. We 100%, sir.
Okay, so tricuspid atresia. Is that gonna affect S1 or S2?
It will affect S1, sir.
S1 is gonna become louder or softer.
It will be soft.
It'll be soft because there is no tricuspid valve. The problem here, Mabel, is you got tissue across like this, but no valve ever carved itself out. How come the valve didn't carve itself out? What fell happen?
I don't know.
Boy. All right, I said, what fell happen? Apoptosis didn't happen, Mabel. And who's the gene controlling that? P53, who's the protein helping out? Big good. No, what are you doing labeling now? Come on,
this,
now. What's wrong with me here?
Something cyclidine.
Mabel, come on now. Or moved on to acid now. Okay, so D-cycle is a big D. Is the protein that carries it out. And the label, phosphatidyliserine and the hitman, gas bases. So tricuspid atresia, Mabel, still your patient. What happens to the CVP? Go up or down?
The CVP will be increased.
Will be increased because it's not going anywhere. It's just backing up. What happens to right ventricular blood flow? Rise or fall?
It's going to increase.
Maybe you got tricuspid atresia. There is no valve there. How do you increase it?
Okay, to decrease because yes, it's decreased.
Wait a minute now. I want to make sure you understand the physiology. Don't just switch. You have no valve. There's no way for blood to enter the right ventricle. Do you understand? I want to make sure you see that physiology. Okay, again, that's why I say don't just start guessing things. Use your physiology, talk it out. That way you don't say the wrong thing. You understand?
Yes, sir.
All right, so you got a CVP rises, the right ventricular blood flow drops. In fact, it's 0. And what happens to pulmonary blood flow?
Pulmonary blood flow is decreased.
Decrease, so S2 splitting, wide or narrow?
Oh, is narrow.
It's narrow because there's hardly any volume flowing across the pulmonary valve. What happens to pulmonary capillary wedge pressure? Rise or fall?
It falls.
Evolved because hardly any flow went into the lungs. Let's see. Okay, that's pretty good.
Thank
All right,
you.
so Dr. Patrice. You're welcome, Ms. Mayo. All right, so the way I know this one is easy because it says singular S1, and then you got big time JB up to your ears. That's because the blood can't get in. So now the question is, how did this child live? In case they ever ask you. The blood came in the right atrium, shunted through the ASD to the left atrium, went to the left ventricle, went up the aorta, come around. Oh, there's a PDA, and went into the lungs. That's the only reason why this baby's alive. That's how the circuit that he's making. That's why if that PDA closes, he's dead. You have to reopen it, else he will die. Yes, Akshay.
Sounds like QRS.
Yeah, you'll have a real tiny, yeah, real short QRS, because right ventricle is not receiving any blood. Yeah, real tiny QRS in lead 2. Oh, yeah, left axis, because everything's going to the left side. It's not even coming to the right. Yeah. All right, so next one. Total anomalous pulmonary veins return. There's all the pulmonary veins keep coming right back to the right atrium instead of the left atrium. So pink blood never makes it to the left side. One more time. All the pulmonary veins, pink blood, returning from the lung. He's coming right back to the right atrium. So what you see on an X-ray is a circle of blood floating around like this because it's just going around a circle. The left ventricle's over here. It never gets to the left. It's just a circle with the right atrium. So you can see the circle. It's just white. That just means a lot of blood. And you see the heart right underneath that. And that's why they call it the snowman sign. It's like a snowman, 2 bodies. Big circle, small circle. Or they'll call it the figure 8 sign. That's just what they describe on an X-ray. And that classic signs for TAPVR. Adam. I said blood is flowing around. That means leaving the right ventricle, going to the lungs, and coming right back to right atrium again. So you see a lot of white going around in a circle. That's because there's so much blood. It's just going around in a circle. It never gets to the left side. Pulmonary veins, total anomalous is the pulmonary veins. They never went to the left atrium. They all went back to the right atrium. So it's never getting to the left side. All right. All right. So the figure 8 sign and snowman sign is how I make that. They don't live very long, obviously. There's no way you can reroute 4 veins. Can't do it. All right, Josh.
Yeah, that was my question.
Yeah, there's no way to reroute 4 veins. These children don't live that long. Next one, truncus arteriosus also has to do with spiral membrane. Matt, spiral membrane says truncus arteriosus says the spiral membrane came halfway down and then stopped. So up here at the top, you do have 2 vessels, but down here at the bottom, you have 1 common trunk because it never came all the way down. You understand that? All right, so that means down here, you just have 1 trunk and blood is mixing right here, the trunk, and then divides in half up here. All right, so with truncus arteriosus, that can affect your S1 or S2. Matt. No, it's not going to affect both. I said, which one is it going to affect? S1 or S2? What? S2. How do you know it's S2? That's not how you know. Add now. Because I just described aortic and pulmonary, which is S2. All right, now everybody make sure. I told you guys, you guys should never miss the first question I asked you. Because in my discussion, you will hear mitral, tricuspid, aortic, or pulmonary. But I told you, when you guys are dazed or just kind of listening, nonchalant, you don't even hear it. As soon as I ask, I see this stall. That means you didn't hear it. Same thing on the test, folks. It's in the doggone question. That question should take you guys 1 second to get it right. If you pause too long, that means you're not seeing that the clue was already given to you in that question. Because they have to use those words. Okay, it's right there. That's all you need. All right, so truncus arteriosus. Instead of the aortic pulmonary, there's 1 trunk here. It never divided. So they'll say singular S2. There's only 1 big trunk here. There's no two vessels. Singular. There's only one valve, opening and closing. Okay? All right, so singular S2 gives me that point. Pulmonary atresia at 9. Pulmonary atresia says you got tissue across here like this. It's not really a valve. It means the valve didn't cover itself out. What the hell happened? If that doesn't happen, what gene is supposed to be doing this job? P53, what protein? This man saying it's 17 times already? It's many times. No. My man had to think about it. How many times have I said Big D today? Come on now, everybody's got to get these points. I've had so many students come back and say, man, Big D was all over the exam. I said, why do you think I scream his name all the time? Because it's on the exam. I found out the guy who did all the research on apoptosis in UCLA. Big old book. I said, I'm not reading the whole book about it. There it is, 4 things I want to know. That's it. That's the 4 things they're always testing. The gene, the protein, the label, and the gas base. That's it. All right, but anyway, so again, same thing. And the label, give me the label. Phosphatidylserine and the hitman. Gas bases. So in pulmonary atresia, that's going to affect us on S2. S2, louder or softer? Softer. Again, they'll say singular S2. Remember, only one valve is present. Follow? All right. So how are we going to tell it's not truncus arteriosus? I told you that's a singular S2. Listen carefully. You got pulmonary atresia. What happens to pulmonary blood flow? Yeah, absent. They'll tell you the X-ray shows no white. There's no infiltrate. It means there's no fluid going in there. They'll say hardly any markings on the X-ray. That's how you know there's hardly any blood going in. That's pulmonary. That's not now. No, it's pulmonary atresia. Because when 2 things are the same, folks, you got to think ahead of time. How do I know which one they want? I don't want you on a data exam trying to figure out which one, because that's when you start panicking. Okay? Truncus arteriosus, pulmonary atresia both have singular S2, but one has hardly any pulmonary blood flow on X-ray, whereas the other one has normal blood flow.
So lungs are almost invisible.
No, they're not invisible, just be black. There's no white streaks in there. Yeah, that's how you know there's no blood.
So please,
I
which one have normal blood flow? Is it truncus arteriosus?
What?
He said another. I said one has a normal blood flow. So which one is it? Truncus
That's truncus
arteriosus?
arteriosus. Pulmonary atresia doesn't have any pulmonary blood flow. You got no pulmonary valve. The only way to get into the lungs, again, is through the PDA on the left side again. And that's why they got to have a PDA or else they die. You understand it, Mabel?
Yes, sir.
All right. So aortic atresia, Steve, you got aortic atresia. Gonna affect S1 or S2? S2 can become louder or softer? Softer. Again, they'll say singular S2. So how do I know it's this one? What's the X-ray gonna look like?
Increased pulmonary flow.
Increased pulmonary markings. Because the blood's getting into the lungs, but it's not getting out on the left side, so it's all backing up. See, so you got 3 with single S2, but we can separate all 3 with no problem. That's if you're listening carefully. All right, hypoplastic left heart. Nolan, you take this hypoplastic left heart. Says your left ventricle is but a slither of tissue. It's not really a true ventricle. If that's true, what happens to your end diastolic volume? So end diastolic volume, increase or decrease? You hardly have any left ventricle? I say you hardly have any left ventricle. It's just a little slither, that's it. Well, there's hardly any room. There's no room to put blood. So there's hardly any blood in there. All right, so EDV will do what? No. EDV will go up or down? Down, because there's hardly any ventricle. You understand?
Yes.
Cardiac output. Down. Stroke volume. Down. Carotid stretching. Down. Fired by 9. Down. Fired by 10. Down. Heart rate. No. Reflex tachycardia. So this one has near maximum heart rate, and a baby was just laying there doing nothing. What's the maximum sinus rate for a newborn baby? Nolan. I'm help him out.
220.
Oh, now he remembers. 220. So this baby will have a heart like 190, 200, and he's just laying there looking up in the sky. That's hyperplasic left heart. There's hardly any blood coming out of that left ventricle. That's why his heart rate has to make up for it. All right, you just saw the equation. If you don't have the volume, heart rate has to make up for it. Keep your cardiac output the same. But they have incredibly high heart rate, which means that they're not going to live long if you don't do something about it. So what do? They reroute everything so that everything goes to the right side. That means you created ASD so that blood comes in the right atrium and goes to the, oh, wait a minute, no, so the other way. We're going to get rid of the left ventricle, just shut it down. All right, so blood comes in the right atrium, goes down the right ventricle, goes to the lungs, comes into the left atrium. Hang on, let me make sure I got this right. No, yeah, they're going to take the right atrium and connect it directly to the pulmonary artery because the pressure is low enough that blood will just come in and go right into the pulmonary artery. That way now blood, when it comes back, will then go to the left atrium and we reroute it to the right ventricle. Your right ventricle will then pump it to the aorta. They just be connected. That's the only way to buy that child a few months because they still die. Why? Because the right ventricle is not made for pumping against the stomach. It's just not made for that. It fails in no time flat. But that's the only thing we can do right now. Adam.
They will have right ventricular hypertrophy.
Oh yeah, they'll hypertrophy and then end up dying from it. Yeah. All right, Victoria, you have a question.
What's the average heart rate for a newborn normally?
Normally is 110 to 160.
Okay, so anything over 160,
Yeah.
reaching 220 would be
200.
Okay.
I think one I saw was like 190. Anytime that. Another way they'll describe it, thready pulse. It looks like a little thin thread. That's how much blood's coming out, a little squirt. When you put your finger on their pulse, you can feel a little squirt. You can feel like a little thread just drawn underneath your fingertip. Very little blood coming out of there. All right, what about Epstein's anomaly? So Epstein's anomaly, Anders, this is yours. All right, everybody watch my hands now. Oh, let me do it here so everybody can see it. Tricuspid valve right here. Right ventricle, I saw right atrium up here, right ventricle down here. Everybody oriented? Okay. Where this tricuspid valve is located, there's some grooves right in the walls. So that when the tricuspid valve closes, it goes right in the groove and holds tight. Everybody follow me? Okay. In Epstein's anomaly, this tricuspid valve develops down here in your right ventricle. So now you have a huge right atrium. They use the word atrialization. You're creating a bigger atrium than normal. You create a huge right atrium. Look at that, a tiny right ventricle. Everybody follow that? What? No, because the tricuspid valve is developed right down here in the right ventricle. Yeah, but that means there's no grooves down here for this tricuspid valve to slide into, which means the tricuspid valve is just doing this all day long. You understand so far? And is there going to be regurg or stenosis? It's going to be regurg. Systolic or diastolic memory? For regurgitative valve, ask yourself when it's supposed to be closed. Because the valve is supposed to be closed during systole. That's how you come up with it again. You understand? Everybody else understand? Again, so you guys don't have to keep guessing. All right, stenotic valves make a noise when it's supposed to be open. So if I give you a stenosis, you say, well, when is it supposed to be open? That's when the memory will occur. You got regurgitate, you say, when is it supposed to close? That's when the memory will occur. Okay, so it's going to be a systolic memory. Systolic ejection or holosystolic for tricuspid regurg. Holosystolic. It gets louder when you inhale or exhale. Inhale. Is going to affect S1 or S2. S1 is going to become louder or softer. It's not even closing. S1, you got to regurg. It doesn't close, so it can't make a noise. So soft S1. Is this a volume or resistance problem? Volume. Hypertrophy or dilation? Dilation. Thick or thin walls? Thin walls. S3, S4. S3 that gets louder when you inhale or exhale. Inhale. What happens to my CVP, rise or fall? It rises because you regurgitate back up in your neck. Pulmonary blood flow, rise or fall? You can't increase in both directions. It either goes here or you go here. All right, so it's going back up here, so it's not going to the pulmonary anymore. So pulmonary blood flow will drop, so S2 splitting will narrow wide. narrow. Pulmonary capital wedge pressure, rise or fall. You was that? See? The whole physical exam every time, folks. You now have the power to figure out the exam for every heart disease anybody can ask you without having to go look it up. Okay? All right. So Epstein's anomaly. The final question I'd like to ask about this is how did they get it? Lithium use in the mother. That's always what they ask. Lithium use in the mother caused it. That one's been well worked out. And what is about the lithium that causes the valve to do this? Nobody knows that part yet. Yeah, we don't know. All right, Victoria, did you have a question?
Yeah, sorry, before you move on, what was the cause of the S2, the long S2 split or the wide S2 split
In what disease?
in the Epstein's anomaly? I followed you up until the S2.
Oh, no, it's not a white S2 splitting. It's narrow. Because you got regurg just going back up in your neck. It's not going through the pulmonary. Right?
I'm kind of confused.
The S2 splitting, when it's widened, is based on the volume going into the lungs. You understand that?
Oh, okay, okay.
Yeah, if you're regurgitating, you're not going into the lungs.
Okay, okay, okay.
Right,
Got it.
that's the narrow.
Okay.
Yeah.
Okay.
All right, a few more slides here. Ductal dependent lesions. Remember, first give alprazolam, take the surgeon created blade like toxic shunt, allow child to grow, and then go to surgery. Josh. The reason why ASD has what? Fixed wide S2 splitting is for what reason? No, it's because the extra volume comes in during both phases. When you inhale, it's coming from the vena cava. When you exhale, it's coming from the left atrium. So there's always extra volume on the right side. Yeah, so that's why it stays fixed. All right, to Dr. Hello, there's a picture. So we put a lot of nice pictures for you guys so you can now visualize this stuff. All right, tricuspid atresia, we just did that. Okay, so valvular, most common causes. I told you I'm always gonna give you most common, because they hardly ever move away from it. All right, aortic stenosis, aging. This is called dystrophic calcification, remember? Because there's so much turbulence around the aortic valve, cells are gonna die. And that's why they calcify right there. Now you have stenosis. Aging, number one cause. Aortic regurg, aging, number one cause again. Why? Because when calcification build up on the aortic valve, after all, it gets heavy enough that it falls in like that. You're gonna hear a lot of aortic stenosis, aortic regurg combinations in elderly people all the time. So aging is also the one cause. Mitral stenosis, most common cause is still rheumatic fever. What's the most common bacteria that causes rheumatic fever? Adonis.
Sorry. Sorry, what did you? The bacteria, I think it's staph.
No, not staph for rheumatic fever.
Or
Gustavo.
strep, sorry.
Okay, yeah, make sure you say the right bug. Yeah, strep pyogenes. I told you guys, use the last name so you don't forget what strep they want. So this is strep pyogenes, rheumatic fevers, still the number one cause of mitral stenosis. You're gonna hear an opening snap or ejection click, Adonis.
I think it's oh wait. So snap.
So say opening snap. Yeah, don't just say snap. It has to be an opening
Opening
snap.
snap. Opening snap.
Yeah, opening snap is a diastolic noise. Remember, mitral valve stenosis is diastolic murmur. All right, mitral valve regurg. Most common cause, Lawrence. Mitral valve prolapse. What do you hear when you listen to that one? Mitral valve prolapse, what do you hear? I don't remember saying snap. Read, what do we hear? No, I said mitral valve prolapse is the one I'm on. I said, what do you hear when somebody has mitral valve prolapse? Let me see, a couple of hands went out. Victoria, what do you hear?
Mid-systolic click.
Mid-systolic click. Why is mitral valve prolapse so common in women? Victoria?
Ooh, I'm not sure.
Chris? It's called estrogen connection, that's it. It makes the valve soft, that's why it buckles. And then eventually it flips. So mitral valve prolapse is also the most common cause of mitral regurg. Because eventually it just flips into the left atrium. So Mrs. Click. I know you have a question?
Can you manipulate the factors, say that aortic pulse?
Yeah, yeah, you can say it that way too, but they usually say agent. But yeah, but aortic stenosis is the most common cause of aortic regurgitation, correct?
They don't work those two.
Yeah, if they don't put agent, they'll put, aortic stenosis. SBE, subacute bacterial endocarditis. What's the bacteria? Gloria. Strep viridans. Eats right through your bowel. That's how you get regurg. Systolic or diastolic murmur, adenine. Regurg. Systolic. Systolic ejection or holosystolic. Holosystolic, it gets louder when you inhale or exhale. Exhale, radius to axilla or not? It does. My man, 9. Hey, my man, blasting back at me. I love that. And before you used to panic every time you looked your way. I'm like, dang, man. Still panicking, huh? Yeah, but now it's right answers and panic, right? Yeah, that's good. Good job, man. All right, that's where I want all of you to be. That way you can actually see the information and answer the question without looking scared, because when you start panicking, that's when you start stalling and the mind just starts guessing. Now it's not using physiology anymore. Okay? All right, and then collagen diseases, Jess. What's the most common collagen disease? Myofan, what's the main protein defect? Fibrillin, how is it inherited? Also, down, what's the most common cause of death? Okay. All right, see, that's why we can just drill things real fast. Just hit the highlights, keep moving. All right, very good. Trichomonas stenosis, rheumatic fever, still the most common. Still the most common, Karis. Rheumatic fever, what bug is that? Staph disease is correct. Trichomonas stenosis. Diastolic rumble or diastolic blowing? Diastolic rumble is correct. Then it says carcinoid syndrome. Carcinoid syndrome is spraying what neurotransmitter at your tricuspid valve? Serotonin made out of what amino acid? Tryptophan used to make what vitamin? Nice is what letter name? B3 deficiency is called what? Pellagra, which presents like another disease called? Hot nose, which means you're dripping what amino acid in the urine? Tryptophan, full circle. Who cares? I'm telling your friends on you, girl. Yeah, now you're getting the hang of this stuff. Very good. That way, no matter which angle a test writer comes at, that's why I like doing these drills. You should never care what angle I decide to take to ask your question. You want your mind to become numb to that. Just like whatever angle you take, I'll answer it. That tells me you're seeing the information now versus you're trying to remember what you wrote down. Okay? All right, so that's trichomonas stenosis. Carcinoid syndrome, remember 5-HIAA. Okay? All right. Next one. Tricuspid regurgitation, acute endocarditis is a Staph aureus. Usually an IV drug abuser. And they say you should always confront them about it because they all deny it until you ask them. Now, what I usually do, here's my way of doing it. So now, with all due respect, George, I gotta say, in our literature, they say almost every time somebody comes in with one of these infections, like acute endocarditis, is because they shared a needle at some point in time. Now, just think hard now. Have you ever been to any kind of party where you shared a needle with somebody using any kind of drug? Then they stare up in the ceiling for a little bit. Oh, wait a minute, there was that one time. There was that one time. Okay, fine. All right, if you say one time, that's cool. Anyway, they've used it more than once. But if you don't confront them, they'll never admit it. Just so you know, you got to confront them. All right, endocarditis will kill you if you pick it up more than once. All right, pulmonary disease is always congenital. Anytime I ask you most common cause, say congenital. That's because pulmonary is protected on the right by the tricuspid and on the left by the lungs. So that means it's hardly ever involved in any disease except you were born with the problem. Name which congenital heart disease we talked about involves the pulmonary valve. Jess. Name the diseases. We just talked about all of them. I didn't say mention all of them. I said just name one. Okay, Michael. Name a congenital heart disease that involves a pulmonary valve. Oh, not VSD. Karina. The Georgia Fellow and pulmonary atresia. That's only two we talked about. We just went through the whole list. Okay, make sure you guys study this weekend. Flow volume loops. There they go. Oh yeah, look at all that excitement. I know. I remember the first time somebody brought this to me. They said, Dr. Madge, you didn't teach about flow volume loops. I said, I didn't. They said, yeah, you forgot. I said, I did. I said, wait a minute, let's sit down and talk about this. I said, okay, here's the loop. And I said, do you see this axis right here? What does it say? It said volume. I said, when does volume rise? Sister Dasley. She said Dasley was a she. She said Dasley. I said, did we talk about Dasley? She said, yeah. That means I did teach you about this volume. Oh, wait a minute, what about this pressure rising? When does pressure rise? Sister Dasley. She said Sicily. I said, did we talk about Sicily? She said, yeah. I said, then we did talk about this. You got lost because they put a picture in front of you. Now you forgot everything I taught you. Folks, anyway, so that's why I put this in. All right, because I saw so many students forget it's the same damn thing again. All they did was put in a picture. I told you, you can't tell the test writer how to test you. You got to be willing, no matter how they test it, you know the answer. All right, anyway, everybody follow along with me. All right, it's all labeled here. So now the x-axis is volume, so that's Dasley. That's how you know mitral valve opens right here at A, closes here at C. And then you have what they call isovolumic contraction. Aortic valve opens at D, and then you have peak pressure at E, and then boom, aortic valve closes at F. Then you have isovolumetric relaxation, and then start the whole thing again. No, it's all labeled for you. All it is is go around with an arrow. It's all labeled. You guys need to be writing. Just watch. Okay. I said the volume is on the x-axis. So at the beginning, mitral valve opens. Again, it's labeled for you already. And then at the end, mitral valve closes. Then you have what we call isovolumetric contraction. And then D is where aortic valve opens. How do I know that? Because blood is leaving. And then maximum pressure right here at E. And then boom, aortic valve closes here at F. Everybody understand? What if I were to ask you, Ashley, where would you find the diastolic blood pressure for this person? Which letter? Yeah, what letter? Diastolic blood pressure for this person. Why letter C? Okay, I'll give you credit because that is the end-diastolic blood, but that's not what I asked you. I said, where would you find the diastolic blood pressure for the person? That's not EDV. If you remember, diastolic blood pressure is where the aortic valve opens. Remember, I said all you gotta do is add 1 to the diastolic blood pressure. That's where the aortic valve opens. So you gotta remind yourself of that. And then you say, oh, letter D. Okay. Systolic blood pressure is letter E because that's the maximum pressure generated by the left ventricle. See? If you want to figure out stroke volume, listen up. You take end diastolic volume C, subtract end systolic volume A, there's your stroke volume. Everything's on this graph, folks. Everything we were discussing is right here. This is just one way of putting everything on one graph to see if you can see it on your own. And yes, you can. Okay? Any questions on this? All right. Yes. Solange?
I have the aortic regurgitation for an external systolic systolic. I thought that the wider it was because the harder the aortic stenosis was. So you would have to push harder and do more force and put more pressure. So that would increase the systolic.
Yeah, it increases systolic, but it drops the diastolic pressure. Because if you increase she's asking about aortic regurgitation. If you increase the blood coming out into the aorta, systolic pressure goes way up. But that aorta will contract even harder because when you descend through the muscle, it contracts. that's gonna push most of the blood right back in the left ventricle. So that means there's hardly any volume in the aorta. So systolic pressure is rising while diastolic pressure in the aorta is dropping. And that's how you get the wide pulse pressure. Yeah. All right, now, if you understand this, Solange, you might as well do this one. Here it is. Look at aortic regurg. See that? Does everybody see? End diastolic volume is way out here to the right now. See? That means if you just tell yourself, oh, he's got a volume problem, then aortic regurg makes sense to you. I mean, they can make it something else, but this tracing is only on the left side, so it has to be aortic regurg. Okay? Now look at exercise. All right, so control here. Exercise, remember, you send more blood to the ventricle, and then it contracts harder because sympathetic tone is up. And that's why you have more volume going and more pressure being generated. What if it was just pressure rising, but volume stayed the same? What's going on there, Lillian? Stenosis of what? Yeah, aortic stenosis. Because you see the pressure goes way up, but the volume didn't change. That's how you know this thing is thick. It's pushing real hard now. Okay? That's what I mean. They can put any pathology they want. Okay? All right. And then here's another one. They put everything on the left on